Thanks, Dr. Bavaria. I'd like to take this opportunity to thank Professor Di Bartolomeo and the organizing committee for allowing us to host the great debate for the Aortic Journal and the CTSNet Aortic portal. This debate is going to be aired on the CTSNet portal at some stage. We rounded up an expert panel.
Turn the lights up.
Vast expertise in this topic. I'm just going to briefly go through a couple of slides, which just to set the scene straight. So we know that techniques for thoraco-abdominal aortic aneurysm has evolved with time. We've moved out from the original clamp and sew technique to the modern perfusion-assisted techniques with varying degree of hypothermia. So what does open surgery offers? It has the applicability of offering the myriad of aortic pathologies, anatomy and connective tissue disorders is unlimited. In experienced aortic center, the morbidity and mortality has been reported, average between 5 to 8 for mortality percent, paralysis 2.3 to 3.8%, and renal failure requiring hemodialysis reported at 1.5 to 5.6%. So TEVAR on the other end, the approved indication for TEVAR as it's out in the literature is the repair for descending thoracic atherosclerotic aneurysm with adequate proximal and distal landing zones. TEVAR is obviously used for and to treat many aortic pathologies, and different centers reported different results on that. The applicability of TEVAR to the transverse arch and the visceral abdominal aorta has been extended using the extra anatomical bypasses, hence the hybrid technique, which is also in this debate today, or the branched and or the fenestrated devices. The long-term durability of these repairs extended beyond the descending thoracic aorta is still unknown. So to avoid didactism, this debate is going to be, rather than just a Q&A, it's going to be a Q&D, a question and discussion. I encourage the member of the panel to feel interactive and if you have any further comments on what your colleague is saying, please feel free to comment. We're going to touch base on different pathologies in this debate, including the atherosclerotic aortic aneurysm, chronic dissection, connective tissue disorder, ruptures, and also how to deal with infected grafts. My first question is for Professor Wu. We know that open repair has been the gold standard for 50 years. Technical improvement in the conduct of the operation and the improvement in post-operative care have demonstrated excellent results in short and long-term cohorts. Could you summarize or give us a short burst from your own experience on these technical improvements seen in thoraco-abdominal aortic aneurysm repair?
Right. To start with, I think advance in the imaging technology has improved a lot on our understanding of this thoraco-abdominal aneurysm pathology as well as anatomy, then how to plan the operation a lot easier compared to 20 years ago. And then that will allow you to discuss and decide which modality of treatment is appropriate for individual patient, and then that's how you start your treatment. That's been a major improvement in the advances. And that's before every operation starts from the pre-op preparation. If you go in unprepared, you're going to fail. And next step is improvement in the monitoring of the organs, like cerebral monitoring, spinal monitoring with MEP and SSCP, and the cerebral saturation monitor, widespread use of CSF drain, and then understanding usage of left heart bypass and circulatory rest, and then improvement in cerebral protection if you use circulatory rest for proximal anastomosis, for instance. All these things come together with cross-fertilization between the centers, from the major center for the technical details in anastomotic, safe anastomotic techniques, two-layer anastomosis techniques, plus advancements in the adjuncts in terms of sealants and glues and variety of things come together with organ protections. That led to the safe conduct of the operation. Then subsequently, advancement in the intensive care therapy, which we have to rely on. You can't just operate and walk away and then following them come back patient paraplegic and dead. And so we have to rely on the intensive care therapy unit and advancement in that organ support to take our patient through. These have been a combination of comprehensive improvements over the last 2 decades, I would say, and that led to where we are now. But we still got plenty more to get to. But that's probably, if I say it in summary, these are the improvement that we see.
I bet. Thanks, Prof. Dr. Caselli, you've reported extensively on open repair. You have a vast experience in this procedure. What about the rate of reintervention after open surgery?
The rate of reintervention is actually for open surgery quite low. You know, if done properly, it's durable. The 2 areas where we see reintervention, one is at the level of reattached intercostal arteries, particularly in patients with connective tissue disorders. And we've treated a number of those patients with just placing endovascular stent grafts across them, and with CSF drainage and keeping the pressure high. Thus far, we haven't had any paraplegias. The more difficult one is the patch aneurysms at the visceral vessels, and we think we've reduced that by using more branch grafts and individual reattachment of the visceral vessels there. Just a starter comment.
Great, thanks very much, Dr. Caselli. I'll move the question now to Dr. Shappins. The patient's aortic anatomy does not limit application of open repair. However, patient's comorbid status can and should. Advanced age, chronic lung disease, chronic kidney disease, systolic heart failure are all considered nowadays in this era as not contraindications to open repair, but frailty and inability to rehabilitate should be treated as contraindication. What's your thoughts on this?
Well, I think it's a very good question to consider who is fit enough for this kind of surgery, because the impact of a TAAA replacement is enormous. So you should think before you start, and certainly in elective cases. I don't mean in urgent cases, of course. We tend to do some preoperative examinations to evaluate the pulmonary function preoperatively, the cardiac function. For example, we do transthoracic echo to consider eventually valve disease or left ventricular function. Coronary angiography is not performed routinely except in patients who had previously either percutaneous or open bypass revascularization. We plan a lung function. Some people say it may be dangerous to put some stress on the patient and to increase blood pressure. We never saw any problem, so I think if you do it in the regular way, it's not a problem. We do also duplex scanning of the carotid arteries, and if we have problems, we will revascularize this first or stent it first. And that's about it. Of course, blood tests and finally use your common sense. If the patient can climb chairs, if he can do bicycling, there shouldn't be no problem. But if you have a, for example, 85 years old man who is just sitting in a chair for the rest of his life, I would say don't start doing this kind of surgery.
Thanks, Dr. Chapin. This is a question now to Dr. Azizadeh. TEVAR, based on your experience, Dr. Aziz, the TEVAR for thoraco-abdominal atherosclerotic aneurysm requires either extra-anatomic bypass for coverage of the paravisceral abdominal aorta, or fenestration and or branch graft for revascularization of these branches. The morbidity and mortality of hybrid thoraco-abdominal debranching and endograft repair, as you're aware, has exceeded that of traditional open thoraco-abdominal repair at centers of excellence. Most institutions nowadays, they have abandoned this approach. As indicated in the literature, the morbidity of the open portion of this hybrid approach does not justify the minimally invasive second stage endograft procedure. What's your take on this, Ali?
I agree with your comments on hybrid repair. It's important to keep in mind that not all endovascular techniques are the same. The hybrid technique of doing an open mesenteric and renal revascularization followed by a straightforward TEVAR tube graft has been abandoned. The techniques of doing branched and fenestrated grafts are probably the way we're going to fix these in the future, but again, this technology is still in evolution, and there's still a lot of room for improvement. The off-the-shelf platforms are currently only applicable to about 40 to 60% of the patients. So a lot of these patients will have to get the custom-made devices, which are not widely available, and it takes 4 to 6 weeks for it to get ready. So open repair still remains to be the only option for a lot of these patients. And we also have the option of doing these sandwich repairs, as kind of popularized by Dr. Lobato. So not all endovascular techniques are comparable.
Great, thanks, Ali. Christian, do you have any comments on this?
Well, at the current moment, I think we all agree that that stent graft and the sophisticated techniques for this all are reserved for the most high-risk patients, the old and the frail. For those that we think that open surgery is not appropriate because of the risk factors they probably may carry and the concomitant disease that Mark just mentioned. But apart from the technical issues and the planning, I think the major concern, of course, is paraplegia in those cases. And since we don't know whether the mechanism of spinal cord ischemia in those cases, for the most part, are interruption or maybe, and this is my guess, and I'm be interested in hearing Joe's comment on this, delayed paraplegia is the most important risk for those patients. We have to consider that type B leakage is probably a major concern in those cases because of the atherosclerotic nature and what we have seen before, the coral reef anatomy there. This predisposes the patient for developing embolism in the remaining sac, and if you get reversal of flow there, you can get embolic spinal cord ischemia, and there's nothing we can do about this at this point. And I think Joe has once given me a nice slide on the delayed paraplegia in those cases. This is an underestimated issue, I think.
Dr. Bavaria.
Well, I think well, first of all, delayed paraplegia is underestimated. It's actually probably the most common problem. I think that the delayed paraplegia clinical outcomes and clinical progress has actually completely validated the GREEP model, or the ETS model of the collateral network, because most, in fact, 95+% of all delayed paraplegias come before 72 hours. So I think that these spinal cords are at risk, but they become less at risk as time goes on. And the treatment paradigm, and this gets into your postoperative care bit, if you don't have an ICU and a staff that can take care of delayed paraplegia, you probably shouldn't be doing any of this stuff, whether it's open thoraco-abdominal aneurysms or thoracic stent grafting of any kind.
Great, thanks, Dr. Bavaria. This is to Dr. Kaiser now. Fenestrated endograft can be self-made on the OR table at some stage, or custom-made to suit each patient's specific anatomy. Branched endograft are also custom-made for each patient. Endoleaks and reintervention are common. The long-term durability of the repair and patency of the visceral branches remain to be seen. Although this technology is not yet widely available, it may be best applicable to high-risk patients who cannot tolerate an open repair. Do you have any comments on this?
I think that the problem with the branch or the branch in branch and fenestrated is very important, this problem, because you know that the rate of rupture of the branch is near 40% in this patient. So this is a big problem. And I think also this is a problem of material. So now in this period we change the original material, and now you are trying to use other type of material. And only when the patient is fit and there is possible of open correction, I do open correction for this patient, only in fit patient. Other patient with not fit situation, I try to correct this by endovascular again, second rate.
Great, thanks. Thanks, Dr. Kaiser. I'm going to go back, I'm going to switch back to Ali on this. We're going to be moving now to chronic dissection. In chronic dissection, Ali, although there is a great enthusiasm for the endovascular repair of chronic aortic dissection, the long-term results are still lacking, and treatment failure as high can be in the literature as 40% in some reported hands. The success of endovascular repair is dependent upon thrombosis of the false lumen, which is variable at the level of the device and unreliable distal to the device. What's your say on this?
I think out of all the pathologies that affect the aorta, chronic dissection is probably the most challenging to treat with endovascular techniques. As we saw in one of the videos that was just presented before this session, perfusion of the false lumen can be a major problem. A lot of times it's very difficult to determine the exact location because there's multiple reentry tears. These patients often require multiple reinterventions, and there's risks of incomplete device expansion, retrograde dissection. So this is definitely the most challenging area, and also probably not for the not well experienced, or the surgeons who do occasional endovascular surgery should probably not attempt to do chronic dissections to start off, because these patients are prone to having a lot of complications.
Thanks, Ali. Christian, do you want to add any comments on this from your own experience with regards to the chronic dissection?
Well, the concept of preventing again comes back to paraplegia when it comes to long-term results. The concept that we developed at the last 10 years was basically staging the procedure. And if you take the chronic type Bs as patients that already have pre-occluded by the nature of their disease process, pre-occluded segmental arteries, I think that risk is probably, this is the population that has the lowest paraplegia risk if you treat them with endovascular or open technique. So I think this is probably an ideal population to study this idea of staged approach in a overall setting.
Great, great. Thanks, Christian. This is now to Dr. Lovato. Acute complicated type B dissection. It's a major issue. What's Bologna's experience on this, and how do you manage that?
For the acute complicated?
Type B dissection, yes.
Well, I think that this is the most important indication for endovascular treatment, because of the low invasivity of the procedure, very fast, and you can treat both complication, rupture and malperfusion very rapidly and obtain rapid changing and aortic positive remodeling. The most important problem is the risk of retrograde type A dissection, as I told you before yesterday. I think that to reduce the kind of risk, you can do two things probably. Reduce the oversizing, and this is very important. We are used to oversize more than 10% the aortic diameter. In aortic dissection, I think now we have to reduce this, this range, not overcome the 10% of the size. And we don't know if the configuration of the stent graft can help in this case. There are a great debate about the role of the free flow, the bear spring, and we don't really know if the bear spring create more problems in the stem, but there are some devices without bear spring that can be used in this case.
Thanks. Dr. Caselli, any comments from your end on the acute type B, complicated type B dissection? Dr. Caselli, would you like to make any comments on that?
No, we, you know, some of the grafts have been approved for chronic dissection and acute dissection, and we've used it. But let me just make one comment about the stent grafting.
Yes, please do.
I'm about as guilty as anybody is putting in stent grafts and fenestrated grafts and branch grafts, prefabricated, on the table, and all the rest of it, in places and in people that I probably shouldn't have. One thing is we really shouldn't fool ourselves about one thing, and that is when we evaluate our patients, when we're looking at our stent grafting, for our own knowledge and for our patients' knowledge, we always get a very carefully conducted, delayed CT scan. But when we see presentations of these devices, and that's not always what we're looking at. We can fool ourselves with 3D reconstructions and with the first phase without using the delayed phase. And so I think we need to be as honest with ourselves as we are with our patients and evaluate these things very carefully, because there still are a lot of unknowns, and it's still a dangerous area that we're working in.
May I say something about
Yes, please,
complicated type B acute dissection? We have also to take in mind that we have another tool in the treatment of this kind of disease, the frozen elephant trunk. We were able to demonstrate that in case of increased risk of retrograde dissection, like in case of dilated acute type A dissection and dilated ascending aorta, or not a good anatomy for TEVAR, we found even useful the frozen elephant trunk, so we can avoid any risk of retrograde dissection.
Yeah, you also got to remember, and I think this is an important point, although I don't think that should be not necessarily the primary, thing, but it should be thought about. But for complicated type B dissections, TEVAR is incredibly life-saving. However, if you look at the most recent two United States FDA trials for stent grafts, which is the Medtronic stent graft and the Gore stent graft, going through the FDA, so this is very good data, very adjudicated. 100 patients, there's a 6% retrograde type A dissection rate. Okay, so I think that number is the number. Okay, no other number is the number. That's the number, because that is a $50 million adjudicated study. And it's got 101% follow-up. So I would, that's the number that I use now as a 6% retrograde type of dissection rate. So, it is real what you're talking about.
Thanks, Dr. Varela. I'm going to stay. Would you like to make any comments, Dr. Yeah, please.
The big problem for acute type B dissection is how to treat the intercostal artery, because with endoprothesis you cover complete the intercostal artery. With the open surgery it's very difficult in the most part of the cases to do a reimplantation, because the tissue is very, very fragile. So this is the big problem, and I think that the necessity to choice is not very, very easy to do all with endovascular, also in acute type B, for the anatomical situation. So I think that the necessity still now to choice between and the other possibility, following, looking at every cases. Every cases need a particular treatment. This is my idea, not standard.
Right. I'm going to stay with you, Dr. Kaiser. In acute complicated type B dissection, we're staying on this topic for a bit longer. Excellent comment from Dr. Bavaria on this as well. The opportunity to promote aortic remodeling or obliteration of the false lumen is greatest in acute dissection. However, it is common to see continued perfusion of the false lumen distal to the device, and in particular in abdominal aorta. How do you go about this? What's your strategy for this? That's for Dr. Kaiser.
I don't understand what you asked me. Sorry, I was not.
Yeah, that's fine, absolutely. So we go back again. In acute complicated type B dissection, Ali, feel free to make any comments.
So basically,
on this.
the question is, you know, patients who come in with acute type B dissection, you do a stent graft repair of the descending thoracic aorta, and now you've covered down to the celiac, but the abdominal aorta remains perfused, and there are multiple reentry tears. All these mesenterics and renals have reentry tears. So what do you do with the distal aneurysm in the abdominal aorta? That's one of the most challenging, I think, technical problems from an endovascular standpoint.
Yeah. Right. Also, in this case, it depends from the local situation, I think. But it's possible to do something with open surgery. It's possible to do something with endovascular therapy. So I think that it depends from the local situation. Usually, I do prefer when there is a peripheral distal perfusion to do open surgery and to do reimplantation for renal, for mesenteric.
Thanks, Dr.
When
Kaiser.
it's possible.
Thanks.
Yeah.
We're going to
I
shift.
think the acute TVAR for acute type B dissection of any sort, whether it's complicated or uncomplicated, is I mean, there's a couple of things. The first one is that usually most of the studies are going to show between a 75 and 90% in-stent remodeling rate, and then there will be problems more distally. And I think that the key concepts there is to stay very algorithmic in your head. You know, the more disciplined you are, the better your results will be. So one of the ways to reduce that maybe would be to extend down to the celiac on some cases, maybe even in a delayed fashion, as Christian Etz was just talking about. That would improve the results possibly, rather than a short segment up in the proximal descending aorta. And the other thing is timing. You know, the great conundrum, you know, the titration is you get better results acutely if you delay, but you get better results long-term, remodeling-wise, if you do it early. So where's this, you know, where's the optimization point? And I think that some of the studies are finally coming out to show that it's probably somewhere between 3 and 6 weeks, you know, somewhere around in there where you get this optimization of two competing concepts.
Right, thanks, Dr. Bavaria. We're going to switch gear now. We're going to go to the Marfan population, or connective tissue disorder, I should say. A question to Professor Wu. How do you approach patients with connective tissue disorder?
Right, and I think the majority of us will agree that if we can operate and do the open repair, and then we should treat them with the open repair for patients with connective tissue disorder. Most of them are young, and then one other factor is if you put the branch stenting, fenestrated stenting quite early age, we put them on the kind of endovascular load for the burden for the rest of their life. And we all have been seeing more and more infective grafts, infected stent graft especially, and with multiple stent graft with multiple endoligament stent and coil and infected, and they are disasters. And then no matter how many try you try, you've got the residual infection. And so we need to be careful. That's why I always encourage that, then propose that the multidisciplinary approach to patient focus, and then the treatment should be tailored to the patient. For connective tissue disorders, first line of treatment should be open surgical repair. If you have a surgeon and the team can provide that optimal service. And otherwise, obviously, of course, you should treat the patient with endovascular if you need to.
Yeah, I think we have the opportunity to have David Piccini here, who just finished a huge paper on the worldwide literature of stent grafting and Marfans.
Yeah.
David?
Yeah, we did a recent meta-analysis with also the help of Joe and other colleagues, and we clearly demonstrated that TVAR in connective tissue disease are really provide really bad results. The only result, good results that we found in the literature are the good results in case of proximal and distal landing, when the proximal and distal landing zone is in the prosthesis. This is the only patients in which TEVAR can be utilized.
So Pacini just says that, that the results are very bad, and he's looked at the world's literature, and we have the largest experience of thoraco-abdominal aneurysms in the world here with Dr. Caselli. So my question, Dr. Caselli, is if you take out all the cases that you do the Marfan's patients do better, open? And if they do, why?
Well, there's several things. One, they're younger and they're healthier. The other thing is there was a time, I guess 20 years ago, where we thought chronic dissection was a risk factor for paraplegia. It's probably not. And actually, in these Marfan patients, they do have patent intercostal arteries which are available for reattachment in almost all cases, which is not true in the 75 or 80-year-old atherosclerotic. So to answer your question, they, as a group, they do much better. The paraplegia rate is extremely low, and the mortality rate is basically almost zero, and that includes the extent twos. However, I think you do have to, if you're going to select out a group, I do think there is a role for stent grafting in Marfan patients. You just mentioned it when there's Dacron at one or both ends. And also I think there may be a role in the emergency situation to bridge to a more definitive repair, to save a patient's life, and realizing that it's being done under that context.
Great, thanks, Dr. Caselli. This is a question to Dr. Gherardi. How would you approach? Professor Wu mentioned something about the infected graft, thoraco-abdominal graft, or the endograft. How would you approach an infected thoraco-abdominal graft?
I'd probably try to send it to Houston if I could. No, I think the infected endograft, as was mentioned previously, we're seeing, unfortunately, more of those than we'd like to see. And I think the treatment for that is still explantation of the stent graft and in situ reconstruction, and then figuring out whether soft tissue coverage is necessary depending on how much of an abscess you have, how much necrotic tissue there is in the area. And for those that have gone down below the diaphragm, and even those that haven't, it's pretty easy to get a fairly sizable portion of momentum up into the chest, and it does a wonderful job, and we've not seen any recurrent infections with that technique. The other thing, if you're going to stay in the chest, is you have to give some thought to that on the way in, and take a serratus flap on the way in that can be set aside underneath the scapula while you're getting things fixed up, and then bring it down through a defect in the chest wall and wrap it around your graft. So in those two settings, we've been fortunate and have not seen any recurrent infections. That being said, though, I do think part of that, and I think this goes back to a paradigm that was put forth earlier by Dr. Caselli's group and Dr. Crawford's group, being lifelong antibiotic suppression. We've not been brave enough to take them off antibiotics after reconstruction. And using that methodology, we've not had any recurrent infections. So,
thanks for this. Any comments from the panel on infected grafts or endografts?
I just want to make a comment or a question. What about, have anyone in the panel experience using a pericardial tubular graft for infection? Because we had an experience and we had a good results in a patient with endovascular prosthesis graft infection, and we take it all out and we put a tubular pericardial graft, and yeah, for sure, it was a very bad patient, and we had a good result. So I would like to know if no one has experience in this kind of graft.
Anyone would like to take this comment from Professor Piccini?
Well, I think it's a good option to use the bovine pericardial tubes to replace infected grafts, but in case of thoraco-abdominals, it's a huge task to replace the whole aorta with these self-constructed grafts, and it is just a nightmare. You better prevent than treat it.
Okay. Dr. Kaiser?
The big problem is a difference between infection in thoracic or in thoraco-abdominal. Two things completely different. And in thoracic field, the problem is the reconstruction. So the technique of reconstruction for esophagus or for trachea. Because in thoracic field, it's possible to change the prosthesis, to change the endoprothesis, because you are increasing to observe a number of fistula after endoprothesis. So you look an increasing number of fistula, esophageal fistula, after endoprothesis. So it's possible to change the endoprothesis or to change the prosthesis. But the problem is the type of reconstruction with, for esophagus and for trachea. And there are many, many techniques. For example, you use intercostal muscle when there is a little through in esophagus or in the trachea. But the problem is this. For thoraco-abdominal, it's quite different. You have to change completely the endoprothesis. So the operation is bigger, is strong, and the problem is which prosthesis you go to use and to repair the type of the fistula. Because the fistula can be also, or for the abdominal viscera, for duodenum, for sigma, for other, so the problem is different, quite different.
Yes, Dr. Stella.
You know, it was mentioned that prevention is probably worthy of note. Unlike prosthetic aortic valves, where there are standard recommendations for antibiotics, we see a lot of these patients that come to us with infected grafts having had dental or urological or other non-site infections that probably a little prophylactic antibiotic may have made a big difference. You know, and the Dacron grafts are never completely neo-endothelialized, and the stent grafts are always exposed, permanently. So maybe more attention to recommending these patients to have antibiotic prophylaxis when they have dental, urologic, and colon evaluations is worth it to help prevent some of these problems.
Right. Dr. Stella, any comments?
I have a short comment about the use of the homograft. We have seen this morning the use of homograft to treat some kind of complication. I think that is a dangerous choice because we observed many cases of rupture after the implantation, and so I don't think is actually a good choice to treat this infection.
Great.
Thoracic and thoraco-abdominal.
Great, thank you, Dr. Starr. We're going to stay with you on another question. We need to switch on to cover as much as possible area in this vast topic. Regarding penetrating aortic ulcer, Dr. Stella, this is a question to you. What's the Bologna approach on this? Do you think this entity should be treated solely with TEVAR, penetrating aortic ulcer?
Luigi, please.
For penetrating ulcer, it depends on anatomy. The way to treat surgically or with TEVAR, it depends on anatomy. The problem of ulcer is that probably you don't have a good proximal and distal neck because there is generally diffuse atherosclerotic disease. So in many cases, TEVAR is not so good as a choice. Anyway, it depends on the anatomy, and the approach is not so different from atherosclerotic aneurysms or other disease. We discuss the case together and decide case by case if the indication, but there is no disease program to treat all with TEVAR or surgery. It depends on anatomy.
All right. Would you like to make anything? No, that's fine. Professor, this is a question again to you, and this is on ruptured descending thoracic aorta or thoraco-abdominal aneurysm. How would you approach this? Prof? This is a question to you. On ruptured descending thoracic or thoraco-abdominal aneurysm.
Well, to save the patient's life, maybe put the TVAR in to start off with if the patient is not stable. And then you can always go back and then do the definitive repair in subsequent kind of time frame. It depends on the pathology and the subsequent the observations. And that probably would be the kind of, if it is a descending. If it's thoraco-abdominal, depends on where it's leaking from. And very often it's leaking from abdominal aorta, which is fairly contained. And that we may have opportunity to repair, open repair in that kind of circumstances. And very often they are rupture of myocardic aneurysms or leaking myocardic aneurysm. Then we should try our best to try to treat it primary open surgery. And then whether we can use some homograph or whether we should use the antibiotics, impregnate and soak and then powder pour graft, whichever way you do, we need to kind of utilize these. So and depends on the individual circumstances.
All right.
The only thing I can add to that from a TVAR standpoint is this is for descending aneurysms. I don't care how it's ruptured, whether it's a ruptured aneurysm or ruptured dissection, but if there's blood in the left chest and you're going to fix it with a TVAR, you have to go from subclavian all the way to celiac. Those are the only ones that survive, is when you go from one end all the way down to the other end. You can't go halfway or try to figure it out. You just have to get in there as fast as you can and do the whole thing.
All right. Dr. Caselli, any comments you'd like to educate us from your extensive experience on rupture?
Yeah, I think TVAR has a role. The ruptured aneurysms, particularly in the thoraco-abdominal situation, they're the ones that are most highly likely to suffer from multiple organ failure and paraplegia. In part because they're susceptible to hypotension, partly from the rupture and partly because they're not prepared for surgery. It's done on an emergent basis. And secondly, because frequently the area where you would reattach intercostal arteries is disrupted, dissected, made not very amenable to reattachment. So the risk goes up. So anything that can buy a patient time and allow things to be transferred to a more urgent rather than absolute emergent situation is worthwhile considering. But having said that, we take most of these people to the operating room and do a definitive repair as soon as we can.
Okay. Just in the interest of time, before I conclude, I'd like to open the questions to the floor. If anybody would like to ask the panelists or anything interesting, Salt, if you'd like to add.
Why don't you bring up the lights for the audience?
Thanks, Dr. Murray.
Could I add one more issue to the rupture?
Yeah, please do that.
I think, like Dr. Caselli, we too would, the most expeditious way for us to get the patient to the operating room and repair it is getting them to the open operating theater. That being said, though, I think once you get them to the operating room, because they are in such extremis, because they are unprepared for surgery, elderly, you have to get a concept in your head that you don't have to fix everything. And you don't have to do an extent 2 on someone who's ruptured if the aorta in the abdomen is 4.6 centimeters, 4.5 centimeters. If it's at the diaphragm, if it's behind the viscerals, you can fix that without having to do the whole thing top to bottom. And if you live to fight another day, I think you'll find you get better results. And then you can solve other problems down the line.
Okay, thanks very much, Dr. Radi. I saw the microphone walking down. Anybody would like to add any comment or ask any question before we conclude?
Matthew Panagiotou from Athens, Greece. What will be the cannulation strategy in these cases of rupture, descending thoracic or thoraco-abdominal aneurysm? Would you use the left common carotid or the femoral combined procedure? Thank you very much.
Anyone would like to take this?
I would say just use your regular technique, because if in these circumstances you're going to do different things, you're going to end into a big disaster. That's my opinion.
Okay. Any other questions? Yeah? Dr. Barrera, how are we doing on the time?
Just a short comment about rupture.
5 minutes. No more.
Sorry? just a short comment about the rupture thoraco-abdominal, very short. We have available, probably it's not in the United States, T-branch technology that's on the shelf, thoraco-abdominal for branch, and that can be an option quite relevant, at least in center who are familiar with this technology.
Thank you. Now, yes, Dr. Kaiser, sorry.
So the problem of the rupture depends if it is a container rupture or open rupture. If you have a container rupture, you can do TIVAR, you can do endoprothesis, you can do what you like. In really open rupture with massive hemothorax or massive blood in the abdomen, I think that open surgery today remains the only possibility with a very, very high mortality. So it's quite different, the two types of rupture, contained or open.
Okay. So if no more questions, we'd like to conclude this session. I'd like to thank all the members of the panel for this great and interesting debate. I thank you all for joining us. This is Mohammed Bashir.